Hello, my name is Dr. Sarah Slocum, and I'm a consultation liaison psychiatrist here at Exeter Health Resources. I would like to welcome you to the next video in our Trauma-Informed Care series. This one is on mood disorders, which you may know as depression, bipolar disorder, and anxiety. As many of you may be aware, rates of these illnesses have risen over the past several decades. As is a common theme for these videos, we are here to impress upon you the fact that each of us is capable of helping patients struggling with these disorders. Unfortunately, there's a lack of recognition of what these disorders look like and a significant lack of resources available in the community. Patients and their families often struggle to find care, which can make it hard for us in healthcare to even ask the right questions. So let's ask ourselves now, what does it look like when we do this well? To me, it looks like availability of various levels of care, inpatient, outpatient, and everything in between, like intensive group and individual therapy, as well as substance use treatment programs. So today, I hope you learn enough to be able to engage with patients struggling with mood disorders and anxiety so that we can point them in a direction of hope. We'll define each of these disorders in a bit, but for now, let's think of our scope. If we are talking about depression, bipolar disorder, and anxiety, who are we talking about? Who is at risk? Well, the majority of people are at risk. Statistically speaking, almost 30% of American adults have been diagnosed with depression at some point in their lifetime. 20% have been diagnosed with anxiety. Overall, 40% of the United States has been diagnosed with one or the other at some point in their lives. Think about that for a second. That's almost half of us. Yet, how often do you talk to other people about this? My guess is that it's not very often. Do you think that there are particular risk factors for depression and anxiety? If so, you'd be right. Women are at higher risk than men. Certain jobs also convey a higher risk, including being in medicine, veterinary medicine, or the military. Younger people and people who identify as LGBTQ are higher risk than others. What about those adverse childhood experiences, or ACEs, that we've already discussed? Those are things like physical, sexual, and emotional abuse, living in a household with substance abuse, divorce, or having a parent with a mental illness. You might remember that the more ACEs someone has, the more likely they are to suffer from depression and even suicidality. So, trauma experiences play a role here too. Now, we can't go much further without introducing some definitions for these disorders. My goal here is not to list the diagnostic criteria for these conditions. Instead, I'm trying to give you an understanding of what these conditions feel like. I also need you to keep in mind that these disorders exist on a spectrum. Some cases are mild and some are severe. Sometimes people struggle only for a day or a few days. Today, though, we're going to focus on the more severe forms. Let's start with depression, or major depressive disorder, as the textbooks would call it. This disorder feels like a weeks-long darkness, a lack of energy, an inability to find joy in things that you love, a heaviness. While events can trigger a depressive episode, they can also come totally out of the blue, which is shocking to some people. People who are depressed can struggle to get up from their bed, to take a shower, even to eat. That's the state that they're in. We also can't talk about depression without splitting out peripartum depression. This is a unique form of depression that has its onset when a woman is pregnant or after delivery, and we'll talk more specifically about that later. A related disorder is bipolar disorder. We're going to discuss this briefly, but focus most of this lecture on the more common disorders of depression and anxiety. People often think that someone who has bipolar is like a light switch, that their mood goes up and down very quickly. That's actually not correct. Bipolar disorder is something completely different. In bipolar disorder, someone will suffer from mania, which is, to an extent, the opposite of depression. True mania lasts at least 4 days, and the person may feel like they're on top of the world. They might have delusions that they're the president or another famous person. They might have hallucinations where they see things that other people can't. They won't need to sleep, and they become incredibly talkative. So talkative that you can't interrupt them, even if you try. They can also be impulsive, having promiscuous sex, spending money in significant excess, stuff like that. Patients with bipolar disorder will typically go from a manic phase into a depressive episode. These episodes, on average, occur only one time per year, or even less frequently. So you see why it's really not like a light switch. What about anxiety? To some extent, we all know what anxiety is. We have a better internal knowledge of anxiety because it's normal to have some anxiety in your day-to-day life. However, when someone has severe anxiety, it frequently falls into a category called generalized anxiety disorder, or GAD. Generalized anxiety disorder takes anxiety that we all experience to an extreme. Instead of being nervous only before a presentation or an important event, people can be nervous all the time. They can be nervous about things that most people would consider normal. This can cause physical symptoms like heart palpitations, upset stomach, or diarrhea. People can even have panic attacks where they feel like they can't breathe or that the world is closing in on them. It can be terrifying. Now that we have a better idea of what these three main conditions feel like, let's shift gears and focus on what causes them. We're going to break this apart into social causes, genetics, and neurobiology. Socially, stressors can play a role in triggering anxiety, episodes of depression, or episodes of mania, which are a part of bipolar disorder. For instance, experiencing interpersonal conflict, grief over the loss of a relationship or the loss of a job, or financial stressors can be particularly impactful and sometimes even debilitating to people with these disorders. Substance use is also tied into depression and anxiety. There's a little bit of the chicken or the egg here. Substance use and withdrawal can cause anxiety and mood symptoms directly. On the other hand, people can use substances to mask the symptoms that they're feeling. For example, when someone is using opioids or alcohol, they can feel somewhat sedated, which might be helping their anxiety, but can also trigger depressive symptoms. Conversely, opioid or alcohol withdrawal can be a very anxiety-provoking experience. It can be difficult to tease apart what's happening for a particular patient, but it's nonetheless important for identifying the best treatment. We also have to remember that while these episodes can be triggered, they actually most often come out of the blue. Let's think about why that might be. Genetically, we are predisposed to these conditions by our family history. Scientists haven't worked out all the details yet, but we do know that people who have depression, bipolar disorder, or anxiety in their family have a higher risk. We know about some specific genes, including the MTHFR gene, which codes for an enzyme called methyl tetrahydrofolate reductase. Try saying that 5 times fast. This enzyme plays a very important role in processing building blocks within cells, such as amino acids and folate. Several years ago, it was discovered that people with certain variants of the MTHFR gene had higher rates of depression. This might be because without adequate supply of amino acids and folate, our bodies and our brains are not functioning to their full potential. My guess is that we will learn more about other genes that are responsible for causing depression and anxiety over the next few decades. I also want to take this time to connect genetics and trauma as they relate to mood disorders. You may remember a part of our Trauma-Informed Care 101 lecture focusing on epigenetics. Epigenetics is the fascinating way that our bodies have to carry forward information across generations. If you've seen Trauma-Informed Care 101, you know about adverse childhood experiences, or ACEs. Remember, ACEs are those things like childhood abuse or neglect, having divorced parents, or growing up in a home with people struggling with substance abuse or mental illness. So if you experience one or more of those ACEs, it actually changes your DNA. Your body goes through different processes and makes different proteins. These messages can even get passed down to your children and your grandchildren, like an invisible scar to our descendants, even though the ACEs are not your fault. I think of this like a long-distance phone call, a genetic voicemail that can pass across generations. Beyond genetics, what is happening in the brain itself? First, let's set up the normal brain and its key players. There's the amygdala, which is involved in experiencing emotions. The hippocampus, which is involved in regulating learning and encoding and consolidating memory, meaning that it lets us actually think back to the things that have happened before. We have the cortex, which controls the higher processes, like general cognition, problem solving, and behavioral control. The hypothalamus, which coordinates between your brain and your nervous system. It acts like a messenger, telling the nervous system what to do. And then we also have the locus coeruleus, a small area that controls our fight or flight response. So in this brain, there's a constant back and forth between these areas, with stimulation of the nervous system that gets regulated by the cortex, etc. Let's start now with anxiety. In an anxious brain, it's the locus coeruleus that really runs wild. Since it controls our fight or flight response, it drastically increases the neurotransmitter norepinephrine, increasing fright. Think of times that you've had an appropriate fear response. A car accident or a near miss, a big presentation, even certain horror movies. In generalized anxiety, the locus coeruleus does this to the level of overreaction. Can you imagine feeling like your life is threatened constantly, even when you're just watching television or sitting at work? What about the brain while it's depressed? Well, some of those other centers go awry. The hippocampus and the cortex shrink, so memories are not encoded or consolidated correctly, and your higher level problem-solving skills decrease. The hypothalamus and the amygdala start overreacting, so all of the emotions feel insurmountable, and the messages from your brain to your nervous system get jumbled. So you aren't thinking like you should be, you can't remember the good things, and your nervous system isn't connected correctly. No one would feel good in that situation. This is also where we should discuss postpartum depression and how it differs neurobiologically from standard major depressive disorder. Postpartum depression occurs in 10% of mothers. Postpartum bipolar disorder and psychosis are much less common, but they're still important to know about because of the risk of suicide and infanticide, or the death of the infant. There is a growing body of evidence that, at birth, moms experience a significant decline of protective brain hormones, including ones like progesterone and allopregnanolone, causing an imbalance in the mom's mood. This sudden change is what can cause the onset of depressive symptoms in the postpartum period. As you can imagine, postpartum depression recognition is necessary to allow a mom to gain treatment. Untreated postpartum depression can have lasting negative impacts on the baby, as the mom will at times be unable to engage with the child to the fullest extent. There are some medications that target these hormones in particular. We won't go into detail on these today, and they're relatively new on the market, but hopefully they'll become more available in the near future. Now that we've talked about who is at risk, characterized these disorders, and discussed the cause, what's next? What's the solution? As you might guess, because there are so many pathways to depression and anxiety, there are numerous solutions as well. Let's chat first about talk therapy, also known as psychotherapy. There are some specific therapies that have excellent evidence to help with mood stabilization and anxiety. One of these, called cognitive behavioral therapy, or CBT, has been proven to be effective in numerous mood and anxiety conditions. CBT helps a person discover how their thoughts, emotions, physical feelings, and reactions are linked. After discovering how they are linked, a person and their therapist can then work to improve how someone notices their feelings and how they respond, both physically and emotionally. A different type of therapy, called dialectical behavioral therapy, or DBT, adds in communication with those others. It helps them understand how to interact with other people, especially when they're in distress. Group therapy, on the other hand, involves therapy with multiple patients and one therapist, which can be particularly beneficial when patients feel isolated because of their condition, such as in grief, postpartum depression, for those undergoing IVF, or for those with substance use. On a brain level, these types of therapies all work because of neuroplasticity, which we also talked about in the Trauma-Informed Care 101 lecture. Neuroplasticity is that thing that allows our brain to be flexible. It literally creates more new neural connections and pathways to help heal the diseased brain. Besides psychotherapy, what else can we do to help with these conditions? Well, there are a lot of lifestyle changes that can have a big impact. For instance, did you know that aerobic exercise like running, biking, or swimming has been shown to be as effective as medications or psychotherapy in the treatment of depression? That's true. Numerous studies have shown that exercising 3 days per week for at least 30 minutes at a moderate effort can have an immensely positive impact. Other exercise regimens, like yoga, have also shown a positive effect in preliminary studies and continue to be investigated. Nutrition also plays a role. Studies are ongoing, but thus far there is significant interest in the role of things like omega-3 fatty acids, folate, vitamin B12, and magnesium, among others. Hopefully, we will have a better idea of specifically which dietary changes to recommend within the next decade. We also recognize that it's hard to find the motivation to make these changes while in the throes of depression. Coaching and psychotherapy can help people get started. Lastly, we do have pharmaceutical medication to help treat these conditions. For depression and anxiety on the whole, we often use oral medications that affect the brain's neurotransmitters, including serotonin, dopamine, and norepinephrine. Remember, these neurotransmitters are the messengers of the brain and are responsible for signaling pathways. Ensuring that they're functioning well means that the pathways are balanced and that they decrease anxiety and depressive symptoms. These medications can help to alleviate the worst symptoms of depression and anxiety, giving space for psychotherapy and lifestyle changes to take effect. Medications can take up to 6 weeks to reach maximum benefit, and some patients may require dose increases. Sometimes people need medications for only a few months, but other patients may require those medications for life. Beyond medications, there are also therapies such as transcranial magnetic stimulation, or TMS, and electroconvulsive therapy, or ECT. TMS stimulates nerve cells using magnets focused on the frontal cortex. TMS is delivered approximately 5 times per week for 4 to 6 weeks. It's an outpatient procedure and it does not require anesthesia, meaning a patient can drive themselves to and from treatments. ECT is more complicated. It has a bad rap, socially, after being portrayed in movies like One Flew Over the Cuckoo's Nest. ECT isn't actually like that. ECT uses electricity to induce a therapeutic seizure. Acute ECT treatments are usually 3 times per week for 3 to 4 weeks, and patients are usually inpatient for much of that time. Some patients require ongoing maintenance ECT, approximately once per month. Unfortunately, because ECT requires anesthesia, it does require recovery time, and patients cannot drive themselves home. In addition, although ECT overall is a very safe and effective procedure, it can have side effects, including memory impairment, meaning that it's frequently used as a last resort. Other new methods of treatment include agents like ketamine, which was initially developed as an anesthetic. Ketamine's initial data looks quite promising. While we don't know exactly how ketamine impacts the brain to relieve depression, the ability to use it in numerous routes does make it an interesting target for treatment as well as future research. The last thing I want to touch on before we wrap up is screening. Screening is what allows us to identify depression and anxiety as problems in the first place. At CORE, we aim to screen all patients at least annually with something called the PHQ-3. This is a brief 3-item questionnaire focusing on depressive symptoms, where any positive response triggers a slightly longer version called the PHQ-9, which has, you guessed it, 9 items. The PHQ-9 provides a numeric value that we can use to roughly classify the severity of someone's depression. For our pregnant and postpartum women, we use a specific version of depression screening called the Edinburgh Postnatal Depression Scale, or EPDS. This is a similar questionnaire, though it has been specifically validated in the pregnant and postpartum population. Both of these screens have a question related to suicide. Here at CORE, appropriate screening and response to patients who have indicated that they are considering suicide has led to patients getting needed care, saving those lives. For anxiety, we have a different screen called the GAD-7, or General Anxiety Disorder 7, a 7-item questionnaire focused on anxiety symptoms alone. Much like the depression screens, this provides a numeric score which can roughly correlate to symptom severity and can be tracked over time to monitor improvement. More information about screening and treatment can be found in the CORE Best Practice Letters on depression and anxiety, which we would highly recommend reading. Now, to summarize, anxiety and depression alone affect roughly 4 out of every 10 Americans. In each family, there are people suffering from these conditions, and the ramifications really do affect the entire family, not only the patient themselves. At the extreme end, these disorders impact someone's desire to interact with others, to work, and even to continue living. We have the opportunity to improve our own comfort level with mood disorders and anxiety in order to help our patients find relief more quickly. Here are 3 things I'd really like for you to remember. Number 1, depression and anxiety impact people across ages, genders, and ethnicities. 2, although mood episodes can be triggered, they can also come out of the blue, and they're not a character flaw or the person's fault. 3, through psychotherapy, lifestyle changes, and medication, there are many avenues for recovery and improvement in the future. Thank you for your attention today, and we hope that you now feel competent to recognize and discuss these disorders in an effort to connect our patients with the care they need.